I'm here in Amsterdam for Health Europe 2025, where the digital health ecosystem comes together for learning, networking, and just a bunch of cool experiences. Here at the event, I'm joined by THT co-host Sophie Turner when we're out on the expo floor and here in the Media Village, having conversations with speakers and big minds at Health Europe to bring you this special feature episode of Talking HealthTech today. In this special feature episode of the Talking HealthTech podcast, you'll catch a number of the discussions that we had here at Health Europe. But in the show notes or the description of this episode, you'll see a link to a playlist, which will have all the other discussions that we had here at the event, plus a bunch of other cool content too. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
My name is Auður. It's really hard to pronounce my name, so you can call me Audi. But I come from Iceland, from Reykjavik City, and I work at the welfare department for the municipality, where we are digitalizing our entire welfare services one step at a time. We've been mainly focused on home care for now and implemented some solutions there and really seeing the impact of what health tech can do for people, elderly people that want to stay at home. So,
amazing.
Yeah.
And before we get into that, because I'd love to hear what you guys are doing and having been at Confed last week and hearing what they're doing in terms of neighbourhood care in the UK and then what we're sort of looking at doing in Australia as well. But I'd love to hear, reading your bio, we have a similar starting point, both started as nurses and now you're leading digital health transformation at Reykjavik. Can you tell me a little bit about your journey and how you ended up in the role you're in now?
Yeah, so I'm a nurse and I worked at the hospital for quite some time in oncology care. And, it just kind of frustrated me how, we are not that far along with using technology to ease up our jobs and constantly just running faster and unnecessary steps that you have to take, which, you could automate or use some sort of technology to help you do it. So I was really kind of improvement focused in my job and I was trying desperately to improve the way we worked at my department. But, it only got me so far and I felt I didn't have the tools or the knowledge to really take things further. So I went to Copenhagen to study business and innovation in healthcare. I did my master's there. I learned a lot, and from there I worked at Philips, and then a startup in Iceland called Sidekick Health, and then it's really fun to work at these companies that are making the technology. But for me, my passion kind of lies with working with the people and public service. So I went to Reykjavik City and worked there, and I've been now for the last 2 years building up a team of professionals that are using technology to provide care. So that's kind of where I'm coming from.
Yeah, amazing. And I loved having a read of sort of what you guys are doing, and maybe we could sort of start diving into that sort of that intersection of that community care and I guess the challenges that come with that. We're experiencing it the world over, but certainly like the workforce, and then how do we bring care back into communities and keep them out of those acute services? Yeah. Can you tell me a little bit about what you guys are doing?
Yeah, so we've been thinking about, before I started at Reykjavik, they had been looking at all sorts of solutions they could use to for the home care especially, and that's been like a 10-year journey. But they started testing solutions that are more maybe aids, to help people, no service attached to it. So we kind of started to focus on technology that are providing some sort of service, that we are monitoring something or providing care via the technology. So before COVID started, we had been preparing for implementing video visits to kind of mainly for maybe people are socially isolated and lonely at home, to have someone there on the screen. We didn't need to drive as much, but then COVID hit and we just needed to start implementing it, and it was really kind of what escalated us doing so. But since then we have implemented video visits and automated medication dispensers, and we recently completed a pilot project for remote monitoring for heart failure patients, and are preparing to procure and implement that solution and scaling it up.
Yeah.
That's the real challenge. And then also we have recently implemented remote rehabilitation for our older individuals living at home. So we have a centralized team that works for all the districts in Reykjavik that it's providing this care. And currently we have nurses, social aides, and nutritionists and a sports therapist. And they kind of all work together to help people stay independently longer at home. And we've seen some great results from, using this technology to help people. And they're really happy about it. They even think it's sometimes, many of them, that it's a better service than having people come to your home. So that's really nice to hear.
Yeah, someone said to me the other day, reframing the way we do healthcare and doing it from the idea that you come into a service as virtual, and then if you get to stay at home, and then if you're unwell enough, then you get stepped up into an acute bed and the hospital, and then if you're unwell again, well, then I guess the ceiling of that is ICU. But having that frame of mind that your first instance with the healthcare system is within your community, it's you're at home and you're getting those services that you need. What are some of the challenges you guys have seen in?
Yeah, a lot of challenges. But we have been trying this, changing the mindset to this digital first approach, because I believe that even if we get them into home care a little bit sooner, we can keep them more healthy and for a longer time, and they don't need as much service later on. Or even if we can just delay it by 6 months or something, it will really help, because we're so short on staff. It's like the main challenge, and we just need to utilize the workforce that we have way better than we do now. And I think with technology we can do that, because I like to say, like, we can't hire our way out of this problem that we have. We have like a huge gap between that demand and supply, and it's only going to grow if we don't do anything. And I think technology is one of the elements that we need to kind of use to shrink this gap. I don't think we maybe can never fully close it.
No.
We can utilize each resource we have way better with technology. But getting the workforce to change this mindset about, using a digital first approach, because they have been, many of them, working a long time in the system, and they're like, why should I stop visiting and put a screen? They don't realize. And because I have clearly seen the impact and how we can really provide as good as a service with technology as in-person visits. And then we can utilize the in-person visit for people that really, really need them. And I think that is high value care. You use it when they need it, but not just as like a scheduled visit. They're maybe fine that day, but later in the week they might really need it. So I think that there you can, really utilize it better.
And have you found any keys in being able to unlock that mindset with the staff? Because I know, like, finding the tech and having the tech there ready to go is only one very small part of it. But being able to change those attitudes and the ways of working and embedding that change, what have you found in that space?
So I think because we run the centralized team and the reason why we centralized it, because we tested, putting the screens, in each district, so the workers that would usually go to people's homes were just trying the video visits, but it didn't work because of the mindset. So we decided to centralize it in one team to build up, knowledge and how we can really work with technology to provide the service. And now it's been, almost 5 years that we have had this specialized team doing that. And it's really now that we're seeing like the light bulb moments. And they're like, they're realizing, we can't hire more people. We need to do something different. And I think it's coming now, 5 years later. It takes time.
It does,
and you just need to be like a parrot, like saying the same things all over again and just reminding them what it can really do. So, I think now is the light bulb moment that we've been waiting for, and we just need to keep going. But now it's more also... we've built the infrastructure and the knowledge of how to provide the service with using technology, but now we really need to scale it up to get more users, because we have done analytics on our user group, but how many could be, for example, put into remote care with long-term illnesses. And we found like 40% of the home nursing could actually go into that service, not maybe only remote monitoring, maybe some other things as well. But I think it is. Yeah, it is 40%.
It's huge.
It's huge, and now we're maybe touching 2-3% of our user group. So it's like huge gap there and a lot of opportunities. So I'm really excited for when that happens.
Yeah. So the next phase. So in terms of like, I guess now and then where you're headed with this next phase of scaling, what's success going to look like in there?
I think we are going to support people better. Like I always try to, think about it from the user perspective, not the institution. Of course, we want to think about how we can use our resources better. But I think if you go it from the user perspective, you are also going to use your resources better.
So important to work back from the user, the patient.
Yeah. So when we scale, I think also you can see like the efficiency in the services. But I think that the people will appreciate this type of service more because it's giving them more independence. They're not like, no one wants to be in a place that needs someone to help them in the bathroom. They want to do it themselves, right? So, changing their mindset as well of how they perceive services. I think that is what,
And, you still have a long way to go. Like 3% to 40% is not something that you can change that overnight.
No.
And a lot of that is bringing the workforce that you have along on that journey with you. Yeah. It's working with those that are entering that phase of their life and showing them how they can be wrapped in your service and have that longer time at home, being independent before they have to rely on home care or aged care facilities.
That's true. I'm really excited for when we, reach that scale because then we really can see the benefit from it. So, now we're just like touching it a little bit. But what I am missing is kind of like, because I don't control the money or the investments, but I'm kind of looking for, I want to see us setting a goal, like saying in 2030, we want to have 40% in this kind of service or something that so we can just say to the workforce, like, this is the vision that we have. We're heading there. And it's not just something we're testing. It's not like a side project. This is we need to focus on.
We're going here.
And I'm missing kind of in Iceland, like this, the kind of a national strategy for this type of service. Now I feel like the government doesn't know what they should do with this. They know, like, innovation, technology, it's nice, but how are we going to use it? Because if we don't start now, we're going to be too late. We're already seeing the problems and the challenges, and we need to start now. And we lack kind of like a long-term vision for the whole country because we are a tiny country.
Yes.
I'm just like, if we can't do it, like, tiny as we are, like come together and work together, like across organizations. I don't. Who can do it then?
Oh, absolutely.
And I also like. We're a small country. We will never have the best health system in the world, but I want to like set us a goal that we will be the smartest one.
Yeah, and you're doing the best by your people, and that's so important. Yeah. And I think if we're measuring how good a health system is by the quality of the people within that health system, then perhaps you do have one of the best ones.
Yeah, maybe.
You can aim to have one of the best ones.
But it's just amazing to see. I'm so thankful for where I work now because I can really see the impact and in the user stories and talking to the user about how this has helped them. And I want to share some of them because like in the remote rehabilitation, we are using a Swedish solution called Happy, and it's like a tablet and like a digital coach that helps people train at home, and they don't need anyone present there to train. And we can follow up with that. And there was this one guy who was stuck in his apartment on the 3rd floor. And he had, it's been weeks since he went outside because he couldn't manage the stairs. And he went into our program, and he's been now for 8 months, I think, and completed over 500 sessions by himself. And now he walks up and down the stairs and even walks to the store, like the longer route, just because he can. And I think this is what like kind of keeps me going, hearing these stories, how we can, really changed, and he feels so empowered because he did it himself, using our support, obviously, but he did this. It's like, it's not us, it's him.
So I'm Paula.
Hello.
I am the global lead for healthcare and life sciences at Kearney, and I'm also the founder of W Health, which is a platform to redesign healthcare with women in mind.
Great. We first spoke 12 months ago in the same event on a slightly different environment. So it's great to be able to catch up again. What's been happening since the last time we spoke?
A lot of things. I feel like I was like such a health newbie last year, and we didn't know what we were coming into, and we had this like massive stage in the middle. There was the heart stage, because women's health is at the heart of everything, right? So we were there in the middle, and just talking to loads and loads and loads of people. And we had arrived with like this little community of like 60 companies, and we just didn't know what we were going into. And we had this hackathon on day one on how do you redesign healthcare with women in mind. If you think about, say, vaccination, or if you think about investment, or if you think about lots of other topics. And then out of that started this sort of like movement, like where we've ended up with just hundreds of people on this platform, 450 companies are now in our W Health community. And since then, we've published a really big paper with the World Economic Forum on how do we redesign clinical trials and research and development for both pharmaceuticals and diagnostics. And we're working on two really exciting things. One, which is how do we change guidelines to make sure that we're putting women at the center of their care, and we're not like doing the good old bikini medicine if I'm going to look up here and then I'm going to look down here, and I'm just going to look at you holistically and everything that's going on. Yeah. And then the second piece is that we need to raise money. So we're in the process of raising a fund.
Yeah, interesting. And so this all ties in with there's an episode in the Talking HealthTech feed that out in Sydney, I spoke with the team from Kearney and different, it was off the back of one of the meetups and workshops and pulling together, I guess, part of the community, which all ties into what you're talking about here. But I feel like it's given that Kearney has the global presence, these are kind of problems and challenges that we're feeling everywhere around the world. Is that right?
100%. And I think this year, more than last year, we're going up against a bit of a movement that is like, well, anything that talks about gender equity or gender anything is a little bit complicated. So we need to continue to drive the change, and change looks very different in different parts of the world. So if you're in Australia, you're in a completely different healthcare system than if we are in Europe, than if we are in the US, and let alone if we're talking about the low and middle income countries. So it really has to be global, but at the same time, it has to be hyperlocal so that we're changing the lives of people really on the ground.
How do you feel about, because there's a lot of attention, a lot of interest, and that's all important stuff. But obviously, as you've kind of suggested, and we've talked about before too, I think the more important stuff is that like what people do about it after an event like this, or like beyond the, we all agree that, we need better equity in healthcare, and that's just kind of like the right thing to say. So beyond that, the important things, how do you actually get people from getting back to the day job after something like this to doing something real?
So that was one of the challenges that I posed to the team last year, which was we putting a really big problem in front of everybody's eyes, and raising awareness, don't get me wrong, is needed. But that sometimes doesn't take to action. And the reason why is because people will come out of here with a brain full of stuff. And if they think about, for example, women's health, they'll be like, well, but it's so big and it's so complicated because it starts with like really early understanding of biology and very early research, but it's also clinical trials, but it's also investment, but it's also diagnostics, but it's like everything. And because it's everything and you feel so overwhelmed, you may choose to do nothing. Yeah. And we need to overcome that. And one of the things that I said to the team is, well, how do we give people the tools to understand in their company, in their organization, what are the little steps that they can take in everyday decisions that are actually going to help us close the gender health gap? And we built it as a tool. It's called the W Health Index. And we've got now 250 companies that have put themselves through the index. So that if I'm a pharma company, I can start to understand, well, how am I making investment decisions? How am I designing my clinical trial? Like, are those the right endpoints? How am I recruiting for clinical trials? How am I supporting women in clinical trials? How am I doing like my medical education and my marketing materials? What am I putting in that little patient information leaflet? Is my pill too big? Can it be swallowed by a female throat? So it's lots of little decisions that you take in say a pharma company or a medtech company that you actually can affect change every single day. So we built that tool, and we really have to see that it's opening the eyes to, yes, it's a really big problem, but it can start to be solved by really little steps that everybody can take.
Love that. So I think too, like you're talking about, that's like such an awesome tool. Keen to check that out. You did make me think, though, like 250 organizations, and it's good to see organizations taking part. The reality, or at least I find, maybe it's just the state of mind that I'm in currently, but there seems to be organizations might choose to take an approach of supporting women's health because it's from a positioning point of view and like it's good for brand and all of those things. Is that bad, or is that kind of part and parcel of the whole journey? Because in the end, it comes down to the individuals and the impact that it has, and we need organization. But we're kind of in an environment, depends on where you are in the world, that if any organization, any government, any level of authority says this is what you should do, or this is what we're kind of at a stage where it almost feels like, well, I can't trust that, or what are the actual motives or intentions there? So I don't know, it's a tricky one, but I often grapple with this, is like, on one hand, we want big organizations to take part in this, but we also want it to be genuine and for the right reasons, if you know what I mean.
100%. And I think I will take any advocacy. So if somebody says, yes, I really believe in this, that in itself is just giving like energy behind the cause, and it's giving it visibility. So I'll take it. What I would like to take is, I'll take the kind of the big ambition and the big commitment, but then I'll take the action. And I think that's why we need to continue to bring all of these topics to the attention of corporations, and especially those that have made a commitment, and going back to them and say, well, what have you actually kind of done about it? And unfortunately, I feel that this year in particular, where there's been a little bit of a kind of backlash, and kind of with almost like backsliding, because we're even seeing people renege on some of those commitments, and being very just very careful and very cautious on the language that they're using. And supporting women's health is not really seen as the right thing to do in this environment, because you are disproportionately focusing on one part of the population, as opposed to this is for everybody. So I would encourage everybody to still think that it is 51% of the population, and there is a lot to be gained from a moral perspective, a social perspective, and also from an economic perspective.
And you got a big presence over here. It looks awesome with the in amongst the
Thank
W
you.
community stage. Types of conversations that are happening there. What are you hoping that people take? I think we've kind of touched on some of it in terms of action, but are there any particular conversations and themes that are really standing out in front of mind?
The main thing that we want people to talk about this year is investment, which is a tricky conversation to have when we don't know what the hell is happening with the global economy. But we know for a fact that we can do all of the advocacy in the world. We can design the best possible clinical trials. We can do all of the kind of changes to guidelines and clinical pathways and so on. If the funds don't flow, we're actually not going to see the innovation that is needed, because we fundamentally still do not understand the differences in biology between men and women. So we need to feed that very early research, very early funnel. And then we need to see some of the amazing, amazing startups that are dotted all around that women's health summit stage, that are just at the beginning of the journey. They may be seed, they may be Series A, and they need to get to B and C, and then they need to get to scale. So that growth part of the innovation funnel needs to be funded, and right now it isn't. So for us, the next week is, how can we just make sure the capital flows?
So my name is Shubs. I am a former GP from the UK. I spent the last 7 years working as a medical director at Audur Health, which is a symptom assessment tool. I was working on our quality frameworks, the communication of our evidence. We had deployed to health systems in the US, in Europe and Africa. I've also worked as a clinician with community health workers in Sierra Leone. And a year ago, I created a podcast, and the angle of the podcast is, what can we learn from people who are implementing AI and digital health with underserved communities, and particularly in low and middle income country settings. The reason for that is because we don't really see that conversation. I mean, this is an amazing, amazing kind of bringing together of people. And actually, it's great because there's a few great examples of people who are working in this space. But we often, when we talk about regulation, when we talk about innovation, the angle that we think about that part of the world, which is actually where most people live, is, how do we take this tech and have an impact there? But actually, one of the things I've learned from working in this space and from meeting people when I've done some work with the WHO is, there's a lot we can learn about good implementation and good co-design from people who are implementing in this space. So that's what Global Perspectives on Digital Health podcast does, and brings out policy and people innovating on the ground, and what do we need to do to implement well.
Super cool. It's great to be able to chat with fellow podcasters.
Yes, exactly.
And I feel like we've talked more at this event off microphone than on,
sure.
But it's good to be able to connect right now. And you've been up on a stage, is that right? You were moderating a panel, I think?
Correct, yeah. So it was on the first day, and it was in conjunction with Doctorpreneurs, which is I'm not affiliated to them, but they're great friends of mine, and they're helping clinicians with careers in tech. And we were talking a lot about yes, I mean, at the moment, there's been this massive proliferation of opportunities for clinicians, particularly in the UK and Europe, to work and have an impact and like shape good adoption and actual clinical outcomes, which, you know, are hard to get in this space, right? And so how do you make sure that clinicians are integrated in the right way? And so whilst I would say, you know, having worked in this field for the last kind of 8 years, at the beginning, you know, anyone who would like look at a startup, a clinician, they'll be like, oh my God, someone's talking to us. This is great. And now it's like, oh, clinicians are like, how do I differentiate myself? There's so much competition. Do I need to learn how to code? Do I need to like learn how product people do things? Do I need to? And so this conversation with some people who have like really been in the field, we're actually talking more about the good, the bad, and the ugly. Like what's hard about integrating? There's sometimes overlapping roles and responsibilities with product teams. Sometimes clinicians in digital health companies are seen as slowing things down. And so we're like trying to think about like, why is that hard? Actually, that's not always the case. Sometimes clinicians can help create, okay, here are some guardrails, and within these, you can absolutely go fast, right? And so how do you do that? How do you operationalize that? That's what we're talking about.
I find that's super interesting because like from my own experience of like working in digital health startups in that kind of 2015-16 onwards era, you're right, is that if there's any clinician that kind of remotely took interest in participating, you're like, cool, regardless of your background. It's you know, this is what we do. And that's definitely shifted these days. I'm just kind of reflecting on that point that you made, though, of I can totally see how that comes about. Often the culture of an organization I've seen is where they'd bring in the clinical person almost more so as a safety, like plug a hole and demonstrate, hey, we got to doctor someone on the board or like within the business because we're a health organization. And often then to that individual, that may then feel like their responsibility is to either, like you say, slow things down, make things more just not rigorous, but almost just adding additional controls for the sake of controls. It's that extra step of bringing them into the clinical, bringing the clinical into the whole kind of DNA of how an organization runs. Much easier to say, much harder to do. But it sounds like there's examples of organizations that have done that as opposed to having that notional clinical advisor where they might flick an email once a quarter and say, what do you reckon of this? You know, so it's quite different.
Absolutely. I mean, 100%. Like moving your mindset and shift to. I think there's a parallel with like legal teams in companies, and often like I know a few folks who are legal, and they kind of, when I've talked to them about the problems that I've lived, they're like totally the same for us. And so what I think the concept is, what like anti-pattern is, hey, we built this thing, let's like get a clinician to like verify and check it meets it, and then but inevitably that will slow things down because totally the clinician will be like, hold on, why is this like this when actually
and then you
had an assumption?
Why did we ask that?
Exactly. And that's literally what happened to me when I was working at Audur. And so I was like, and Audur was a great place to do this because Audur was like one of the companies that like leaned into like the ground was fertile because they were leaning into EU MDR regulation back in like 2019. And so this was the place where we're like, hey, let's really think about how we can do this. And actually the ROI back for us to invest in this effort is kind of how the Marines say, like, slow is smooth, smooth is fast, right? So where do we need to slow down and where can we still go fast? And if we can define that together and actually have clinicians to like make sure our assumptions are kind of right, make sure we're actually working on the right bit of the problem, understanding really right at the beginning, like what is the risk of this use case? What is the risk of this context? And then like actually working with our design team and product team and engineering team to like, okay, we've got a really good hypothesis on how we can like mitigate this. And then we had clinicians who were working with our quality engineers on actually testing it. And so we had high confidence before deploying. And then you need the after deployment, like quality improvement loop, where you can then analyze the data with a clinical lens, not just a product lens. So bring all of that together to like, okay, here's what we need to focus on improving. Here's what's kind of falling off. And that really matters to the value that we're creating. Getting that right, people then saw the value of like, oh yeah, like actually it is worth investing our time in getting this right. So yeah, we didn't always get things right all of the time. And there was lots of pushback initially on the process. And so I think another takeaway was don't build a process until you first built relationships. So take the time to understand how our product managers are making decisions in that context, how engineers are thinking, how the design team are thinking. And then you're like more able to like actually learn, wow, that is awesome. Actually, I hadn't even thought about it that way. Actually, if we apply this to now how we frame this in this clinical context, wow, actually we initially thought about this in a very limited sphere, but actually it's opened our minds in some ways. So anyway, might seem a bit esoteric, but it can happen like that.
Yeah, it's important going in with that mind frame of like it's may break the mold of what you're currently thinking, but that's sometimes the whole point. Lastly, Shubs, I've been thinking about like, you know, where your passion lies at the moment in terms of, as you mentioned earlier, application technology, digital and AI into, I guess, underserved communities or areas that need it. Because I often think this too, is that where we bleed this line sometimes of, at least where money goes, sometimes money in digital health or more broadly wellness and longevity goes in from people who have a hobby of measuring every metric they have, you know, in this bucket of the worried well, to then further invest in their hobby of measuring all their metrics, calling it AI in healthcare, and then kind of retrofitting and saying, well, this is serving, everyone in the community, when in reality, someone who lives in Western Sydney doesn't really care about the how much REM sleep and every other kind of level they have. Ultimately, they're managing chronic disease, or they need to get a doctor's certificate so they can go to get paid because they didn't get to work today. So I feel like this gap between like what healthcare needs and where we put money into, and sometimes, not always the case, but it can sometimes be this thing. And often the technology say, well, let's put some more technology into the area that needs it. But it's not even digital literacy and access to technology and all those things. I just feel like sometimes we're a little bit, hammers looking for nails in terms of like, where can we put this to make us feel a little bit better about these things?
Yep.
Are there examples of things you're like, well, hey, look, this is actually, we're doing things at scale? Because I do see there are examples of, that argument of potentially in underserved communities or nations where they don't have access to anything, so potentially access to AI is access to something better than no one.
Yeah.
But that I find is also a really interesting concept.
Oh man, you've touched on so many things.
It wasn't even a question. I was just telling stuff.
No. Okay, let me riff off this. I have lots of strong and sometimes maybe unpopular opinions about this, but I think a few years ago we were really well disciplined about, generally, like, I don't want to generalize too much, but generally people understood, okay, work backwards from the healthcare and transformation goal that you want to achieve, and then think about work backwards from that, okay, and how might we do that, and think broadly from a systems perspective of what interventions will work. And within that, there are opportunities to use technology effectively. But actually, much of it might be actually people innovation or systems design innovation.
Yes.
We forget that. And so I see so many examples of us somehow regressing to now, because of like FOMO and vibes. This is a once in a generation opportunity. Yeah.
We've had like 5 once in a generation opportunities in the past 10 years.
Yeah, and it kind of is, but LLMs have become a goal again. Like even multilateral organizations who should be kind of thinking about this better. I don't want to name any names, but we all do. We all do it to some degree. So it's not about someone. It's all of us, right? Instead of let's get LLMs into this underserved setting, it's let's actually think about how we want a really good healthcare experience and healthcare delivery to look. And work backwards from that. And yes, then you will have like the right problems and the right use cases to say, oh, these are the ones where like we talked about the guide rails and the things like, where can we move fast?
Yes.
Those are like the problem spaces where like, wow, okay, let's really explore this. And so I think, yes, let's do LLMs in healthcare, but let's attach it to an actual end that everyone agrees with, basically.
Yeah. No, I like that.
So,
hey, lastly, because we should wrap so we can do more things, but any other final thoughts, takeaways, stuff you're taking away from Health Europe specifically that you'd hope? Because, in the end, the best outcome of some of these events is people don't just leave the conversations here at the exhibition centre.
Yeah.
We can apply some things back into home. Is there anything you're seeing that people might take away for betterment of the ecosystem?
Yeah, I mean, so of course, like one of the big takeaways that people came up to at the session that we had about clinicians in health tech was like, oh, thank you for sharing what's hard about it. So we talked about failure, we talked about what's hard. So I think that's a really good takeaway, that it's great. Health is such a great lighthouse of how to do a conference well. And I would love to see more conversations about what's hard. We do, as an ecosystem, need to create the ecosystem level psychological safety to make it okay to talk about that. How will your investor let you talk about what you effed up on, right? That's hard. But I feel like there is potentially protected spaces that we can talk about what's really hard. So that's one. And two, I've been roving around and finding a few really cool examples of people who are here at Health Europe, who are creating impact in Africa and India. Oh, cool. And so I'm kind of trying to do a little segment in letting them talk about what they're doing. Yeah. And I would love to see more of that, a track about that. I know it's Health Europe, but we have so much to learn from each other. Why don't we have a track where there's actual innovators, community health workers, people coming from these settings who can teach us a thing or two about what's going on there?